Okay, so if everybody, little housekeeping, just everybody, it looks like everybody's on mute. Everybody knows the drill by now. We've all been doing Zoom for long enough. But so, hi everyone, thanks for joining us. My name is Sadie. I'm a librarian here at the Oakland Library. And I'm really happy you're all here tonight. And I'm really happy that Mason is with us tonight to do this program. I'm really excited about this program. When Mason reached out a while back, I was extra excited because I'm a pregnant person right now. And so it is both something that's generally interesting to me, but then also particularly interesting. So, and I was excited for the library to collaborate and host. So thank you, Mason, for being here. So we'll have time for a Q&A after. So if you have something you'd like to ask or like a big juicy question, you can save it till after, but there will be time for questions during the presentation as well. And you can raise your hand, or you can maybe don't raise your hand. You can if you want, but you can just ask those questions. You can type them into the chat. And so, and we will get to them either during the presentation or afterwards. So before we start, I just wanted to give a brief introduction to our guest and speaker tonight, Mason Marie Wilson Tenev. Mason is a dedicated and compassionate professional, weaving through the realms of midwifery, postpartum therapy, and psychedelic research, born with a passion for ushering new life into the world and facilitating profound healing experiences. Her journey has been one of purpose and exploration. And I'm going to let her share any more details about her experience and background that she wants to. Yeah, and I think with that, I'll just go ahead and hand it over to you, Mason.
Thank you, Sadie. I appreciate it so much. And thank you, everybody, for being here at this time of night where it's dinner time and bedtime, and it's evening time, and the sun has gone down, and it can feel like midnight. So I really appreciate everybody's time and attention. And I think I actually see one of the families I have worked with as midwife in our gallery tonight. It just warms my heart to see everybody, to see you in particular. So my name is Mason. I am a licensed midwife. I am also a second-year PhD student in anthropology and social change at the California Institute of Clinical Studies, where I study the self-directed use of psychedelic modalities in the postpartum. So I come to you as a practitioner, a researcher, a midwife, a curious person, and an anthropologist. I am also a psychedelic journey guide, which means that I assist in preparation prior to journey and integration after. I sit with a person through their journey to assure safety and aid them in staying focused on goals and intentions. A skill set that is very, very much like midwifery. And it was my working with families who challenged my ability to care for them through their postpartum trauma, depression, and anxiety, who spurred me to look for new novel methods and to challenge the prohibition of psychedelics. So I'm going to go ahead and just share my screen here, and we'll get to this part. So I also served a one-year internship with Postpartum Support International in 2004. I was curious even then about how best to support postpartum families. So, legal disclaimer. Psychedelics are deprioritized in Oakland and Berkeley. They are not decriminalized. That does mean that you would pretty much have to throw a brick of mushrooms at a law enforcement officer to get yourself arrested. But please understand that these are still largely not legal substances in most of the 50 states. Other molecules that I speak of, such as MDMA and LSD, are scheduled and enforced in the same way heroin is. Ketamine is legal only in clinical environments or taken at home with a prescription. I do not advocate for the extra legal use of psychedelics due to the legal risk, and no part of this discussion should be taken as recommendation. In addition, there are real harms to extra legal or independent psychedelic use, not the least of which are the possible legal ramifications or the possibility that substances may have been adulterated with harmful additives. So if you engage in psychedelic use, self-directed psychedelic use, please make use of Q-Test or Dance Safe. Those are two places where you can find testing kits to test for fentanyl in particular. Now, a word about words. I recognize that not all people who birth identify as women or as mothers. This is a controversial and somewhat polarizing topic. I will use the word mother and birthing person interchangeably. So, the history of plant medicine use. The timeline of psychedelics can be segmented roughly into three distinct epochs. Indigenous use, the era of prohibition that began in the mid-20th century, and the contemporary Renaissance. For centuries, if not millennia, what we know is that plant-based medicines have been employed for holistic healing, and a current culture of self-medication and psychedelics for mental health persists. It has never gone away. Now, I think it's also really important to know that we generally in the Western world discount most of Indigenous research. We do not consider what we publish as what Indigenous wisdom as research. We consider randomized controlled trials as research. I think it's really important for us to look at what constitutes research and how we know what we know. And I included this photograph in this top left of this beautiful cactus. This is called San Pedro. It's more commonly known by its indigenous name, Wachuma. And it's actually everywhere. It's indigenous to this area. It grows very, very well. And now that you know what it looks like, you'll probably see it absolutely everywhere. It's sold at Trader Joe's and Home Depot fairly frequently. Just as an aside, it is psychedelic. It contains the same active ingredient as mescaline. As peyote. The data strongly suggests a positive correlation between psychedelic use and improved mental health, particularly depression and post-traumatic stress disorders. Indigenous use of psychedelics has challenged the authority of church and state, leading to its prohibition by European colonizers. It's very challenging to come into an area that does not recognize your authority because of a connection to the divine, a connection to the environment. It was only by undermining those connections that colonialism could take root. Colonialism has not disappeared from psychedelics, but it takes the form now of appropriating religious experiences without reciprocity, and in the overharvesting of slow-growing sacred plants, especially peyote. I think it's very important here to recognize the history of Maria Sabina, who was a woman in the mid-20th century living in Oaxaca, Mexico, who introduced Gordon Wasson and his wife to psychedelic mushrooms and reignited the psychedelic renaissance. He gave her his word that he would not expose her or publish her location. And of course he did in Life magazine, causing her tremendous dislocation from her community. And the rest of her life she lived with heartache. I think it's really important to understand that colonialism has not yet died. Okay, before we go back, I'd love to just kind of open this up to conversation. We're going to switch into another topic here, but as we go, I'd love to just have anybody unmute or write in the chat. It's a little bit hard for me to see since you're small up there in the corner, so maybe Sadie, if you could help me out. If there are any questions or people, just unmute yourself and we'll just act like we're in a big room having conversation. Maybe thoughts, questions, anything to add here?
No.
Go
ahead.
Go for it. Talk over each other.
I had a thought actually on the note on language.
Mm-hmm.
Are you familiar with the term parturient?
Yes, and that term has not really hit the colloquial use yet. So I find that I have to describe that one so often, and I get such quizzical looks that it really stops a conversation. It's an interesting word, but it hasn't yet really taken off.
I ask because I've used it in papers that I've written about gynecology and midwifery, with just a brief explanation in the beginning that it simply refers to a person who is pregnant.
And I think it's an excellent academic word for sure. It just hasn't quite hit the streets yet.
Cool.
Okay. So Schedule 1 drugs, let's talk a little bit about this. LSD, MDMA, cannabis, psilocybin are all classified as Schedule 1 drugs. They were classified in the mid-20th century at different times, the earliest in about 1953, the latest in 1985 by the US Drug Enforcement Agency. So Schedule 1 means that they are addictive and have no known medical benefit. It is the highest risk category. It is also interesting to note that heroin is a Schedule 1 drug. So heroin and psilocybin and cannabis are all in the same bucket. You might imagine that there would be some political reasons for this, and not necessarily safety efficacy. So human psychedelic research never stopped, even after prohibition, but it did reach a nadir in the past 25 years before experiencing what's considered a renaissance or a revival, initiated generally by scientists in Germany and pressure in the United States. Presently, there's a solid foundation of research encompassing multiple fields: human neuroimaging, psychology, psychopharmacology, and others. Notably few studies, however, specifically address postpartum anxiety and depression, but we'll come to that later. There are literally thousands of studies on efficacy, and safety, and the non-addictive qualities. It doesn't take much Googling to find some. So, with all of this, why are psychedelics still illegal? It's really a great question. Well, similar factors led to the prohibition of psychedelics by European colonizers and by Western governments in the 1960s. Resistance to church and state authority. For us in the modern era, really had to do with state authority. Specifically in the 1960s, we saw resistance to the Vietnam War by those who engaged deeply with psychedelic modalities. It's very difficult to go on deep psychedelic journeys and then be interested in engaging in a political war overseas. In addition, the randomized controlled trial became the gold standard somewhere at about the 1960s, and psychedelic research is not well studied by randomized controlled studies. And so the research that was being done found that it couldn't keep up with the changing evidentiary norms. So psychedelic studies, as you might imagine, are impossible to blind. Can you imagine being told that you have either a placebo or the active ingredient? It's very, very challenging. Set and setting, you've heard those terms, really difficult to replicate from one study to another. Also, psychedelics really don't work on an illness treatment evaluation model. They just don't really lend themselves to that kind of Western study. They really do treat diseases of despair, like depression and anxiety. And those diseases of despair are often not well studied by Western randomized controlled studies. So these are also still illegal. So the study includes laborious processes of obtaining study licenses from the government, which is the government has very little motivation for drawing potential backlash by allowing these studies to happen. I mean, can you imagine what it might be for the government to receive some backlash on studying and funding psychedelic studies for those hippie lefty liberals? I think it's really important to also acknowledge that there is a racial component to the war on drugs. In fact, the war on drugs really is a racialized war. So it's a little beyond the scope of what we're going to talk about tonight, but I want to just introduce that part of the reason that psychedelics were made illegal, remained illegal, really has to do with fear of otherization, and the fear in particular that cannabis was being used by Hispanic people and Black people to initiate resistance to the Vietnam War. In fact, the term marijuana was actually not coined, but was deliberately brought into our our national lexicon over the word cannabis because it sounded more Hispanic and therefore more frightening. I don't choose to use the word marijuana for that reason. I use the word cannabis. So there are literally thousands of safety studies on psychedelic medicines. But as I said, very few actually investigate postnatal or perinatal mood disorders, PMAD. A couple of good reasons for them. So let's just talk a little bit about how psychedelic modalities align with the childbearing year. Well, perinatal mood and anxiety disorder, PMAD, affects about 1 in 10 birthing people. It is the most common complication of pregnancy and postpartum. A couple good reasons why we don't know this necessarily. One is that when you're asked, oh my gosh, how are you doing? You have the cutest baby. Isn't this just the best time in your life? Most people don't respond with, actually, I'm having a difficult time getting out of bed. We don't have a lot of support and scaffolding for new mothers. And to feel uncomfortable, anxious, sad, depressed, or traumatized in the postpartum period feels very personal, as if the birthing person themselves has somehow failed to be living the dream of a perfect postpartum. And so that really does cause people not to reach out for the help that they need. In addition, we're very, very dislocated in our modernity. So even if a well-meaning friend or family member wanted to help, they probably wouldn't know what to do or what to say. So PMAD is the technical term. I really like postpartum depression and anxiety, I think because I'm old and that's what I first learned in school, and so that's kind of stuck with me. But I think it's really important to think of perinatal mood disorders as a trifecta: biopsychosocial discomfort. So the bio has huge hormone fluctuations. If any of you have been pregnant or given birth, you know that the hormone fluctuations are just intense. The oxytocin levels an hour after you give birth are higher than they will ever be. Your progesterone levels are lower than they will ever be. And they swing wildly in pregnancy, birth, and postpartum. That is really, really important. If you're curious about the importance of hormones in our mood and how we connect to other people, I highly recommend Julie Holland's book, Moody Bitches. Really important to understand. But I think it's just important to know that there are huge hormonal fluctuations, lack of sleep, also unhealed prior trauma. So many of us carry around unhealed sexual trauma, dislocation trauma, trauma of development, of maybe misattunement with our primary care providers, disconnection from self, the trauma of capitalism and modernity. It's almost impossible to be a completely healthy, non-traumatized person in our modernity. On top of that, many people, about 45% of all birthing people, report that they have come out of their birth process with some trauma. So then we have some disconnection from self, partner, community, and the divine. You'll hear me mention the divine, and I don't do so in a religious context, but rather in a recognition that perhaps what we see in front of us isn't all that there is, and that every other community, all Indigenous communities in particular, have some way of measuring, of naming, and of being in relationship with the divine in a way that our modernity has lost. And I don't mean that people aren't religious. I mean that they lose connection with the more than self, the transpersonal. Let's talk a minute about birth trauma. So I have a picture here of a C-section scar, and I don't mean that to be triggering. Not all people who birth surgically come out the other side traumatized, although a good portion of them do. And not everyone who has what looks to the provider like a peaceful home birth aren't traumatized. So birth trauma resides in the body, mind, and in the framing of the person who birthed. But having to heal from a major abdominal surgery after giving birth is a physical, emotional, and hormonal burden that contributes to birth trauma. And the C-section rate is going up. It did have a small dip, and we see that it's actually gone back up after COVID. Birth trauma is not gently or well or competently held in our society at all. I think the most common thing I hear when people are sharing with me that they felt traumatized is that part of what made them feel really traumatized afterward was being told, at least you and the baby are healthy, which is just so dismissive of the birthing person's experience of their birth. Perinatal mood disorders and birth trauma both are extraordinarily underreported, extraordinarily undertreated. The two standard therapies I have as a midwife are talk therapy and prescribing SSRIs, each of which have significant drawbacks. Not everyone feels comfortable taking SSRIs while breastfeeding. They have poor efficacy overall and unwanted side effects, which can include sexual or mood dampening. Talk therapy can be very, very expensive, even with good insurance. That can be very challenging to find the right fit in that early postpartum. It's a little bit like dating. And anybody who's had a baby knows that just hauling yourself up and making that connection when you are already very, very low can sometimes be a burden too high to scale. Kaiser right now only allows one visit per month to treat perinatal mood disorders. I find that that is just inadequate to the task. So what's left? Well, psychedelics hold significant promise for addressing pre-existing trauma, birth trauma, and in alleviating discomfort and symptoms. And the promise offered, let's see, importantly, to address the bio side, psychedelics offer the hope of neuroplastic growth. So that means that they actually can stimulate the growth of new neurons, which we once thought was impossible after childhood. That occurs for psilocybin and MDMA in particular. We also now know that perinatal mood disorders, postpartum and depression in general, are the result of what can be poetically called an unquiet mind, overactive default mode network. If any of you have read Michael Pollan's book, he writes extensively about the DMN or the default mode network, and the amygdala, the part of our brain that largely is responsible for emotion. So instead of upregulating parts of our brain, which feels like that might make sense, if any of you have personal experience with psychedelics, we feel very upregulated, sometimes stimulated, lots of visuals, where it's a very, very active process, but actually it quiets part of our mind. And that's thought to be part of its mechanism of action. It reduces activity during and following the psychedelic journey. I think is really interesting. So I'm going to take a quick second here and check in with the chat, make sure there aren't any questions here. Oh, thank you. Maybe bitches. Oh, right, of course. Oh, Emily, you had a question about pharma. It just says pharma and question mark.
Sorry, I was on mute. Oh, when you were just talking about a few slides back, some of the reasons for maybe potentially having scheduled for psychedelics being part of Schedule 1 drug. I was just pondering about loss of revenue from pharma as well as part of the picture, the political picture.
I don't know that that was really a part of the original scheduling, although I can say that that's a significant pressure on the government to reclassify and reschedule those drugs. The commodification of psychedelics and the potential for patenting psilocybin and patenting therapies that used to belong to us all and be the birthright of all humanity is really significant. So the capitalization and commodification of psychedelics is a real question and issue. Turning psychedelics into medicines that then can be patented and used to treat disorders, which is really not an appropriate use necessarily of psychedelics, only because that's not so much their mechanism of action, not because I feel like it's personally inappropriate. It's just, it doesn't really how they work. So I
sorry,
that,
I guess I was thinking more like loss a revenue potentially from like SSRIs and anti-anxiety meds and other meds that are being used for various PMADs, that like potentially having alternative therapies that are not like within the same controls could lead to a loss of revenue potentially in
Got it. I
modalities.
understand. Okay. This is really complex because on one hand, there's a lot of pressure on the government to reschedule these drugs so that they can be commodified. But the marketing of these drugs, of ketamine in particular, and of psilocybin journeys, and then MDMA, which should be coming on the market next year, is a little bit more of a one and done, which is part of their marketing strategy, as opposed to here is an SSRI that you will take every day for the rest of your life, or every day for some indefinite amount of time. So you have pressure from some new industry who are wanting to reschedule, and then there's some pressure from the pharmaceutical industry who are seeking to protect their profits, exactly as you mentioned. But the use of SSRIs is beginning to fluctuate, and we're starting to see in some populations that for the first time it's actually decreasing. And so the pharmaceutical industry, which is like a shark, it has to keep moving or it dies, is now looking for the next thing. And I suspect that that next thing is going to be some way to commodify psychedelics and to assure their use for the long term. I'm not sure how they're going to square that circle. I'm curious about it. It's part of my study. So I think it's a really complex question and a really insightful question. Okay. So, I think it's really important. Also, it's an interesting note here that the amygdala is the part of our brain that is responsible for giving us stress dreams or bad dreams, particularly first thing in the morning. It's much more active as the morning time gets closer. So if you've ever hit the alarm and gone back to sleep and had a bad dream, it was probably your amygdala that was really active there. So part of the mechanism of action here is a quieting of the amygdala. In particular, this is very, very strong with MDMA. And one of the reasons why MDMA is an incredibly powerful anti-anxiety medication or treatment. Okay, so let's get to a little bit of what we know. What do we know about psilocybin and the childbearing year? Well, not a ton. We know that indigenous peoples have historically used psilocybin during pregnancy and breastfeeding, and this differs. And when I say indigenous, I am very well aware that there is no one indigenous peoples. But in my study of indigenous use, I can see that there is a lot of plurality in how it's used. But for the most part, indigenous people have used psilocybin during pregnancy and breastfeeding, and even given it to small children. This is not a universal statement, but it is to some degree true. We know that the half-life of psilocybin is about 3 hours, so 5 half-lives. A generally accepted standard for breast milk clearance is 15 hours. So, well, what does that mean? Well, I'm not sure yet. We don't know. We don't study we haven't studied psilocybin and breast milk yet. So still relatively untested in biomedicine. Early studies and indigenous traditions suggest that psilocybin can be a powerful treatment for postpartum depression and have low incidence of side effects. 2 mechanisms of action here. We talked a little bit about the quieting of the amygdala and the default mode network, and of making new pathways in the brain and neurogenesis. I think a really useful way to think about how ketamine, psilocybin, and MDMA can work for all people, but of particular importance in the perinatal time, is to reset our historic thinking patterns. So if we think about how we think, our brains are really efficient, and they tend to think in the same ways and the same things, and you can kind of get into some pathways. And I like to think about this as a meadow with ski tracks in it. So if you've ever thought about cross-country skiing, you can see that it would be much, much easier to ski across a meadow taking the tracks that were already laid down. That is a useful analysis and a useful metaphor for how our brains work. And what these medications do, what these modalities do, is just create a fresh fall of snow so that we're able to break out of these tracks and engage in some new thinking, and maybe step back and investigate how we were thinking about our framing, our relationship to self, other, partner, community, and the divine. It allows for some plurality in how we're feeling and what we're thinking. So what do we know about ketamine? Well, this is a really interesting one because ketamine, of course, is the most accessible right now, although I use accessible with some air quotes since a ketamine therapy session costs somewhere between $2,000 and $11,000. And $2,000 is what you can get some sessions at home for, and in clinic with 2 therapists and a series of preparation session, and then the session, and then the integration sessions. They're really, really expensive. I think the cheapest one I found was about $5,500, which is out of pocket and out of reach for most people. So what do we know about ketamine and breastfeeding? Actually, there's been one study done. Phil Wolfson, who runs a ketamine clinic in San Anselmo, has actually looked at breastfeeding and ketamine and has found that ketamine in nursing mothers doesn't seem to affect the baby. Not enough of it gets to the baby. So ketamine has a long, long history of use as an anesthetic for children. So unlike the other medications or modalities, we actually have a lot of clinical study here, a lot of clinical data on its use for children, and it seems to be safe. When it's used as an anesthetic, it is many times the dose that it's used for psychedelic use, first of all. But I think it's also important to know that we have 0 infant safety data, and we might not have a lot of infant safety data here in terms with low use, that's what I'm looking for, with low doses over time. We don't know that. We only know high doses and single use. So that is the bulk of those are my slides. I'm going to stop my share and kind of just get into some discussion here. I'm really curious to hear from you. I'm curious if you have questions. I'm curious to ask about your use and curious about all the things.
Hi, my name is Mika. I'm curious about any do you have any resource list of studies that you've mentioned here that we could dive into on our own time?
That would have been a really great idea, Mika. And you know what? I did not do that. I don't know why. As I was kind of thinking about this afternoon, I was looking around for the resource list that I actually didn't create. So that wouldn't be hard to do. If y'all let me know what resources you want, I'll put together a resource list and make sure that Sadie has it. That was.
In part, I asked because I'm in midwifery school and I, would love to add some of this information and just study some more about this and add it into whatever I'm, studying, writing, and all of that.
What are you particularly interested in? And I'll make sure that you have it.
I mean, just in general, what you've been talking about, just the use of psychedelics postpartum for postpartum depression or postpartum mood disorders.
For sure. And I can send them to you in a thimble because there really are not a lot. A lot of what we know, we're extrapolating from the thousands of other studies on depression and anxiety.
Cool. Okay.
Oh, I had another thought about that. What was my if it comes back to me, I'll share it with you.
Thanks.
Thank you for this presentation. For fascinating. Something I'm also a midwife and very interested in active and birth trauma work. So it's really lovely to hear about your work. I'm curious about if you know if there's anything looking at about the hormones of postpartum and interactions with some of these psychedelics, in terms of anything around the interplay of oxytocin and various mechanisms, because it just seems cool.
No, there really aren't. We do know that MDMA contributes to elevated oxytocin levels, but in people who have unhealed childhood trauma, it is possible that their oxytocin receptors are mitigated by that early trauma. And so part of the reason that they suffer from postpartum depression and anxiety at a higher rate isn't because they're not making enough oxytocin, it's because they're not receiving, their receptors are, they have just low numbers of receptors. And there's some research here by, it's quoted by Julie Holland. I do really like her. I don't want to quote her every time, but her book, Good Chemistry. I'll go ahead and put that. The library is definitely not paying me to share my favorite books. But Julie Holland has, she cites some studies and does some writing about oxytocin in the postpartum and the contribution of our own history of trauma and how that might assert itself as perinatal mood disorder as we birth our own children. And that's about as close as we can get. We do have some information about oxytocin again, and especially MDMA, some on psilocybin, but no one has made the clinical link to perinatal mood disorders. And again, part of that reason is because it's just unethical to test on postpartum lactating women. There is going to be one study that launches in January, and it will be very, very interesting to watch the results of this. Dr. Larry Lehman at the University of New Mexico has licensed to study MDMA on postpartum women who are suffering from opioid use disorder. And I suspect that he's going to try to wrap in some investigation of oxytocin levels too. He's now gotten he's got his clinical research license for his facility, and he is busy fundraising like crazy. And I do expect that they'll start recruiting for that here shortly and begin. I'm hoping to see that published in about a year. That was Larry Lehman.
Thank you.
Mm-hmm. If you give me a few minutes, I can certainly look for his fundraiser links. He sends them to me all the time. So they're definitely looking to try and raise some money. Did that answer your question about oxytocin?
It does. Thank you.
Okay. So what I'm finding as I talk in the community more about psychedelics and perinatal mood disorders is that I quietly have people come up to me and say, I used this postpartum, or I did an ayahuasca retreat when I was pregnant and I'm a little worried, or I did just this last week in clinic, someone asked me about having had a mushroom journey before she knew that she was pregnant. And that was part of what spurred my dissertation research on the self-directed use of psychedelic medicine. I realized that an absence of clinical information is not stopping people from engaging with the psychedelics in the same way that the legal prohibition did not stop people from using the psychedelics. So prohibition, lack of information isn't stopping people. It's just increasing some of their shame and maybe making them reluctant to talk about it. But that also tells me that the therapies that we have, which again are basically SSRIs and talk therapy, are just not up to the task. So I'm really, really curious what people are doing and have been doing. And part of why I'm really interested in engaging with the community is I'd like to normalize psychedelics use and reframe the need for people to find peace and healing in their postpartum. There is absolutely nothing shameful about seeking a way to address the dis-ease and the trauma that people feel postpartum. The difficult part, the shame is in the medical community and the provider community for not coming up with better resources for people. It is not people in seeking to be healthy, whole, and less comfortable. I'll get off my soapbox now. If there are any other questions.
So I guess in response to that, for what it's worth, I'm one of those people who used mushrooms in my pregnancy before I knew I was pregnant. I mean, I don't have any problem sharing that because my child is now 21 years old. And I was like, oh, whoops. And I traveled to Mexico where I met a physician who specialized in psychedelic plant medicine. And so I asked him, I was in my first trimester of pregnancy, and I asked him, like, oh, I did this. Do you think it's okay? And he was like, don't worry about it at all. And then I said, well, I thought I was just having bad menstrual cramps, so I was taking kava kava tincture. And he's like, oh yeah, that was way worse. not that it was alarming, but he was like, that would be more of a concern than the psilocybin.
Right. So all of us, I'm assuming we're all over 18 years old here, but all of us are the product of the DARE generation. So we're all product of prohibition. And that means that we've all been sold a line of goods essentially about how dangerous psychedelics are. And depending on your age, you were probably told that it can scramble your DNA, that it can make you crazy, that you could be locked up in an asylum. I mean, there was the age of reefer madness, and I'm old enough to remember books like Go Ask Alice that highlighted a young woman's jumping out of a window on an LSD trip, and that became the dominant narrative, and it was partly used to scare us all away from questioning their use, their efficacy, and also our birthright, and helped us not challenge the enclosure by medicine, by the law of what has always been free and available to us all. So there are many, many people now who are kind of coming to terms with what it might be to either use psychedelic modalities or to have used psychedelic modalities. And I'm so glad to hear that your child is grown and healthy and well. And also want to acknowledge the pain and shame that people are carrying around, the secret that they're carrying around too. Let's see, partner worked with a curandera in Mexico. Her recommendations: pregnancy, smaller doses with prayer. Yeah, I don't really get into reciprocity and the importance of ceremony, but that is an incredibly important part of engaging with psychedelics. I use mushrooms during pregnancy and postpartum for my depression, 7 months postpartum now. I really appreciate your bravery in stepping forward and talking about this. This is part of normalizing the need to find treatment and relief from the discomfort and the suffering of depression and anxiety. And these kind of conversations, I do believe, are what's going to move the needle. And as we do that, it's very important to do so with our eyes wide open and make sure that we understand that psychedelics do have some potential harms and some drawbacks. One of them, again, like I talked about, is the potential, especially for molecular medicine, of being mixed with other ingredients that we may not be able to determine. It is really important not to open portals and doors unless you have scaffolding around you in order to help integrate what comes up from those journeys. So I'm all about making sure that there is a guide too. There are other guides or places for you to engage in integration with the community, with partner, with therapist, with guide. So I really appreciate everybody's talking to me, and I will be recruiting for my dissertation work in about 6 months. So I may reach out to you with your permission. Any other thoughts? Let's see. Very interested in potential for psychedelic healing and cancer treatment and prevention of recurrence. Here, this is such a very, very interesting topic, and Gabor Mate has written and spoken, so has Peter Levine. Both of them have written and spoken about this extensively. So Peter Levine developed somatic experiencing, and Gabor Mate, of course, has been instrumental in making us understand that everything's about trauma all the time. And I do love him very much, and I respect him very much, and I am a practitioner of compassionate inquiry, his modality of therapy. But also I do really appreciate his framing of trauma and our experiences and how they get locked in the body and how they can contribute to cancer. And I also want to be very careful about not blaming the person who has become ill for not processing their trauma. If only you had processed your trauma differently, maybe you wouldn't be ill. So I feel like this is a fine line, and one that I'm still actively engaging with for myself. But I think it's really important to have these conversations. And I see Miana has a hand up question.
Yes, this is Mayana. Hello, thank you for this space. First and foremost, this has been a really interesting conversation and just hearing and participating. My question was, is this research mainly done on those who have taken it like in microdosing, like throughout the days or over a time period, or more so to like a larger dose in one sitting, or is that based on like what treatment they're seeking? Like say that they're going in for a more clinical, or to have someone like chaperone them through a trip, that's more so bigger dosage setting, or yeah.
Okay, thank you. Tell me how to pronounce your name again, Miana?
Mayana?
Miana, okay, thank you. So I think I understand your question is this research that I'm talking about on microdosing, mini dosing, or macrodosing, or deep dive journeys? Is that your question?
Yes.
Okay, most of what I study are what I would call deep dive journeys. There are 3 classifications of psychedelic use. There's the microdose, which is subclinical. You take it just enough to have some shift in your body and your brain chemistry, but less than you would notice. You're still able to function throughout the day. I think Ayelet Waldman in No Bad Days, that was the name of her book. Sadie would probably know, but she's a local writer who wrote about her own experience with microdosing, and she wrote about how her dog just felt fluffier and she loved him a little bit more, and the trees were a little bit greener those days. And then there's a mini dose, which is where people might take a day off, have a smaller dose. I do not recommend this with MDMA, by the way. It does not work. Microdosing and mini dosing do not work for MDMA. Please note that. And then there is the deep dive journey. And most research has been done on these larger, high dosages. So there is some research coming out on microdose, and I think that we're going to see more, because that's really where pharmaceuticals are going to get involved. I suspect we're going to start to see commercially available microdoses in our area probably in the next 18 months. They are available now at retail stores in Oakland and San Francisco. And there's a huge community out there of people who engage in growing their own mushrooms, who can gift microdoses, which is a pretty common thing. But my study is really about large deep dive journeys and macrodoses. So doula is yellow in the trenches. Okay, you're a doula and led postpartum talk space from 2020 until recently. 6 months postpartum, heard so much shame and conversation with folks who use them pre and postpartum. I'm here to learn. Would love any recommendations for pages to follow this conversation. Well, Moms on Mushrooms is one page. They tend an Instagram page. They tend to be really focused on selling their microdosing regimen. I feel like 90% of all the Instagram pages out there that engage with psychedelics are really trying to sell their webinar, their ebook, or their classes, something along those lines. But they do have some good information. Let's see if I can get you. There is, I might have to follow up. There is actually a book of Women and Psilocybin, and it's totally escaping me right now, but that's actually a useful one. She's a local author as well, local to West Coast at least. And in terms of following the conversation, I mean, occasionally I'll post some stuff as I create it and as it comes through the pipeline for me, but I have yet to find a really great resource for psychedelics and postpartum. And that was part of what spurred me to wanting to research this academically, as I realized that there's a gap in the understanding, both social and academic. And you're right, there's so much shame. You get questions about psychedelics all the time. And so you're finding, is that Mika?
Yes.
Yeah? Am I pronouncing your name properly?
You are, actually.
Okay. Because so you're finding that you're getting questions and people are sharing with you that they're actively engaged with psychedelics regularly in their within that childbearing year.
Yes, absolutely.
That is just so interesting to me. Yeah. And as they're engaging, as they're talking with you about it, what is their perspective? Are they curious? Are they shameful? Are they like what's their framing around their behavior and their use of psychedelics?
I mean, I think a big question oftentimes is around like safety. And so they're asking me about that. And I don't I'm their doula, I'm not the provider, but they're seeking sources to learn about safety or learn from other people who are, you know, using psychedelics in that childbearing year. And I feel like I don't have a lot of information to share. And so then some people are choosing, you know, not to, but most people are, because they've already had a practice before, are continuing. And I've heard mixed like experience, maybe that it feels different in pregnancy and birth than it did prenatally for them.
So you're finding that I'm sorry?
They have to adjust, like there's an adjustment, maybe. It is different, is what I've heard from several folks.
So I'm hearing you say that the people you're working with, some of them have a history and a relationship with psychedelic medicine, and it becomes ongoing for them, either through their pregnancy or more likely into their postpartum.
Mm-hmm.
And they're looking for some safety, they're looking for some guidance and not finding guidance.
Yeah.
Okay. Well, interestingly, I'm actually co-authoring a paper that we plan to publish next year on the self-directed use of psilocybin for trans people for post-operative surgical pain, because I found that also in the trans community, there's now actually an organized community of people who have gotten together to share information about how to heal their physical pain with psilocybin post surgery. And I was very, very curious. This group has been so generous in allowing us to come in and engage in interviews because I found that this was a group of people, seems like similar to these pregnant people you're working with, who decided that they all needed to get together in community to share resources and to kind of be in solidarity, since there was not any information published for them. And that is, it's very interesting to me to know where people are getting their information and what the needs are. And part of why I'm engaging in my dissertation research is to identify this. I've identified this gap in the academy here. No one's really looking at psychedelics in postpartum, and wanting to study what is safe, what isn't safe, and what's known and not known, and then publish about it so that we can maybe start having some resources for folks. But right now, it seems like there isn't a lot. So I don't know, maybe it would be worth thinking about a focus group or taking this model from the trans community that I have recently been engaging with and applying that to to the childbearing year. That wasn't something I had thought about, but that's an interesting thought. And Carrie's on her way out. If anyone has a question. Oh, okay. Yes. So Sadie is saying that she is happy to forward messages. And I did put my contact information in here. You're all welcome to contact me anytime. I'm available by email, pretty responsive. If you don't hear back from me in 24 hours or so, it's because it went into the ether. Please reach out again. I'm also available. I almost never answer my phone, but if you text me, I'm pretty sure to get it. And you can, if you're on Instagram, which I am very occasionally when I don't have papers due. And then just the psychedelic midwife on Insta. Okay. So for that trans resource, that's someone who's going to have to contact me privately. This is a confidential group, and we'll protect their anonymity. So I can send your person's information to them, but can't share their information with anybody else. But I suspect that they would be very welcoming, very welcoming group. Okay. And just one last thing before we all say goodbye is that there was one client who about 14 years ago challenged my misconceptions about cannabis use in pregnancy and made me curious and challenged what I thought I knew in my belief system, and took the time to educate me, and that's part of why I'm here. So thank you to that person.
Okay. Mason, thank you so much for that presentation. It's very interesting. And thank you to everyone for your questions and for sharing your stories and creating a really great conversation and Q&A after the fact. Mason shared her info up above in the chat if you need it. And also I've shared my email address. If anybody needs to reach out for me, reach out to me for any reason, please feel free. And I guess that's it. If no one has any other pressing questions, I guess we're done.
Okay, and I'll hang out here for a short bit, Sadie. Thank you all for your time and attention. I really appreciate it. It means a lot to me. And thank you so much to my clients in the mix.
Thanks, everyone.